Next slide, please. We should remember that the aim of the treatment of hypertension is to prevent cardiovascular complications. The answer to the question when to treat is simple, and that is you treat when you diagnose hypertension. But that does not necessarily mean pharmacological treatment. Anyone with hypertension should have a proper advice about lifestyle. We'll come to that later. When should we use drugs? If the blood pressure is 160/100 or above, that is to say stage 2 hypertension, then drugs are needed. If the blood pressure is less than that, that's to say mild hypertension or stage 1, then generally a change of lifestyle, if it is followed properly, is enough to control blood pressure. Drugs are only needed in the presence of some additional factor which makes the patient more liable to complications. This includes diabetes, chronic kidney disease, the presence of end organ damage of hypertension in the heart, like cardiomegaly, in the eyes, retinopathy, in the kidneys, significant albuminuria, or impairment of kidney function. Besides these, if the cardiovascular risk in the particular patient is high, then drugs are needed. The cardiovascular risk can be obtained without difficulty from charts usually present at the end of textbooks and sometimes distributed by drug companies. If the cardiovascular risk is high, then the benefit of hypotensive drugs is more, because we know that controlling blood pressure reduces the cardiovascular risk by about 25%. So, if a patient is obese, has high cholesterol, and is, say, diabetic and smokes, and his cardiovascular risk, say, 40%, then controlling his blood pressure will bring it down to 30%, an advantage of 10%. While a patient who is thin, normocholesteremic, non-diabetic and non-smoker, and has a cardiovascular risk of, say, 10%, then the reduction in his risk is only 2%, which makes the use of hypotensive drugs in such a patient questionable. What is the target blood pressure that we aim at when we treat hypertension? Our aim should be to make the blood pressure normal, that is to say less than 140/90. In the presence of diabetes or chronic kidney disease, which themselves make the patient more liable to complications, then we aim at lowering it to a less than that, that is to say a level of less than 130/80. Now, let me take the two components of the treatment of hypertension in a little more detail. Diet should be low in salt. Weight should be optimized, not overweight or obese. Smoking should be stopped, and alcohol should be stopped or reduced to a minimum amount, and exercise to be encouraged. 4 main groups of drugs are usually used in the treatment of hypertension. These are diuretics, beta blockers, ACE inhibitors and angiotensin receptor blockers, and calcium channel blockers. Besides these, occasionally other drugs might be used, like methyl-dopa and hydralazine, usually as an addition to one of the previously said groups. What are the factors that affect your choice of a drug to to a certain patient. The presence of another disease or condition in the patient might affect your choice, the so-called compelling indications. For example, the presence of asthma might make you avoid using a beta blocker. On the contrary, if the patient has angina, then beta blockers will become preferable. The development of side effects might enforce changing the drug in a certain patient. The availability of the drug and the price are obvious factors of importance. There is no use of prescribing a drug that is not available in the market, or a drug that is so expensive that a certain patient can't afford. Besides these, individual variations that are not explainable might also occur. A patient might respond to a certain drug and doesn't respond to another drug for reasons that you cannot always tell. Most of the patients with moderate or severe hypertension usually need more than one drug. In fact, some might need 3 or 4. When we combine the drugs, we should take into account the effect of the drugs on other organs. Some combinations produce favorable results. For example, combining a beta blocker with hydralazine will have a favorable effect on the pulse rate, because one of them accelerates the heart rate and the other one decreases the heart rate. On the other hand, some combinations might have an unfavorable result. For example, combining a beta blocker and a calcium channel blocker will have an unfavorable effect on myocardial contractility, because both of them depress myocardial contractility. When the blood pressure is severely elevated, that is to say, a blood pressure of 180 systolic over 120 diastolic or above, the condition should be taken more seriously. We speak of urgent and emergency hypertension. Urgent hypertension when the blood pressure is severely elevated but there is no target organ dysfunction. Emergency hypertension when it is severely elevated and at the same time there is signs of dysfunction of end organs like hypertensive encephalopathy, myocardial infarction, pulmonary edema, deteriorating kidney function. In emergency hypertension, usually parenteral drugs are needed, and the aim is to bring the blood pressure down to safe levels. That is to say, a blood pressure of less than 160 over 100. We shouldn't aim at making it normal, because too much lowering might produce signs of ischemia and sometimes ischemic damage in certain vital organs like strokes or myocardial infarction. The blood pressure should be brought down to safe levels within hours, not within minutes. Bringing it too rapidly, again, is liable to produce signs of ischemic changes or damage. Urgent hypertension can be treated with tablets, and the aim is to bring the blood pressure down to normal or near normal levels within a matter of days. I like to end up by saying a few words about resistant hypertension. Resistant hypertension is defined as hypertension which is not controlled in spite of the use of 3 drugs, including a diuretic, by a patient who adheres to them. We should approach this situation in the same way we approach any situation when we give a drug and don't see the expected result. We should make sure that the drugs that are used are of good quality, they are not vomited by the patient, and the patient has no gastrointestinal disease which impairs absorption. We also make sure that there is no other condition which counteract the effect of these drugs. For example, the patient might not be on a low-salt diet or has a kidney disease which impairs the excretion of salt, or the patient might be taking at the same time a drug that elevates blood pressure, like analgesic anti-inflammatory drugs or steroids, or a sympathetic drug, which might be contained, some of these drugs might be contained in remedies that are sold over the counter and the patient might not be aware of them. If we exclude these causes, then we should also put the possibility of secondary hypertension, because secondary hypertension is usually more difficult to treat than primary hypertension.